Herpes zoster, the reactivated form of varicella. Some intriguing questions will be answered today. Why only one dermatome is involved in zoster while varicella is a systemic infection? What is Hutchinson's sign? What is the difference between herpes zoster oticus and Ramsay Hunt syndrome? Some complications like post-herpetic neuralgia and segmental paresis will be dealt with. Herpes zoster is the most common example of wolf's eye. We will also learn to eyeball which dermatome is involved. Now let us deep dive into the topic. Now coming to the pathophysiology of zoster. First of all, the patient should have had varicella infection in the past, which is also known as chickenpox. It is a systemic infection. You get the vesicles all over the body. Now the VZV virus from the cutaneous sensory nerve endings travels in a retrograde fashion. So it travels from the skin towards the spinal cord, but it gets the dorsal root ganglion where it resides. Now it doesn't reside in just one dorsal root ganglion. It resides in the whole chain, sometimes even the nucleus of the cranial nerves and autonomic nerves. Now due to aging or immunosuppression, when the immunity of the patient is down, the VZV reactivates. It starts from one dorsal root ganglion. The VZV and other ganglions, the whole chain starts replicating, but the systemic immunity gets triggered and it suppresses the replication everywhere. But by then this ganglion has already replicated to a great extent and the virus then travels in anterograde manner towards the skin. Now that dermatome where the replication was highest, that dermatome gets the vesicles, pain and inflammation. Now if you get a case of zoster, the first question that will arise is which dermatome is involved. So we should have a basic knowledge of dermatomes so that as soon as you look at the patient, you know which dermatome is involved. So on face, angle of the eye, the angle of the mouth. Between them is the V2, which is the maxillary branch of trigeminal. Above that is V1, the ophthalmic branch, and the mandible area up to the chin is the V3, the mandibular branch. Now coming to the ears. Ears are supplied by C2, the cervical branch spinal nerve. So this is spinal nerve, these are by the cranial nerves. Now coming to the body. The shoulder is involved. If the shoulder is involved, be sure, and the sternum, it is C5. Up to the shoulders, C5. Above that, neck, C3, C4, C5. Sternum at C4. The nipple is supplied by T4 and the belly button T10. Now coming to the upper limb. Most of the upper limbs are supplied by cervical branch. Now towards the thumb is supplied by C6 and the little finger by C8. Between that is C7. Now coming to the lower limb. Lower limb is supplied majorly by lumbar. The medial malleolus is supplied by L4. Now coming to the, here only I should say, the lateral malleolus by S1. Now coming to posterior aspect, axilla this way if you draw a curve, and the lower back, spare the lower back, is supplied by thoracic. Above axilla, above this curve is cervical. Now lower back by lumbar. As soon as the sacral area and most of the posterior limb is supplied by sacral. Already said, lateral malleolus by sacral S1. Now coming to the clinical presentation. Few days before the eruption of the vesicles or the skin lesions, a patient might get prodrome. The patients get dermatomal pain and paresthesias. There is a condition known as zoster sin herpete. This literally means zoster without the lesions, the skin lesions. So what happens? Only pain is there in the dermatome. There is no skin lesions. So it may be confused with the visceral pain. And very important is heart attack. If this zoster sign herpes is on the left side on the thorax, it might mimic heart attack, MI. It depends on where the pain is. Like it might mimic the renal colic pain, the duodenal ulcer pain, or the cholecystitic pain, pancreatic pain, depending upon where the pain is. If there is only pain and no lesions, it might mimic that underlying visceral pain. Now coming to the rash. This is the rash of zoster. So it starts with erythema. We can see this, there is erythema here. Then it progresses to papule and then vesicles. And these vesicles are grouped. But only this picture doesn't confirm it is a case of zoster. You have to see the whole dermatome. This is only the rash, how the rash looks. Otherwise, if this picture is only considered, it might be herpes simplex as well. Many a times you will see black center, depressed black center. The vesicles collapse. The center is the first to collapse. So the center epidermal roof gets necrosed. That is why you will always see a center having a black dot. Again, only this picture doesn't confirm zoster. You have to see the whole dermatome. A very close differential here can be Pedris dermatitis. So in this patient, you can see the grouped vesicular rash over here. As this is involved, this is T4. Then a bit of T3. So inflammation can spill over to contiguous dermatomes. So it never crosses the midline. Few vesicles might be there due to overlap of innervation in the midline. Now if you see the dermatome lateral part of the chest, it is in the upward direction. Again, if you come over the back, again this is like this. So you can see the direction of dermatome. If this dermatome presented with zoster sign herpetic, then the very close differential would be MI. So these are other patients. The rash is over the midline of the scalp and predominantly above the angle of the eyes. It involves the tip of the nose and the lateral surfaces of the nose. So the dermatome will be V1, the ophthalmic division of the trigeminal nerve. Now if there is a rash or vesicle at the tip of the nose or at the side of the nose, this is Hutchinson signs. It means if the tip of the nose and the lateral surface of the nose is involved, the eyes must inside will be having the inflammation or the infection. Inflammations like keratitis, conjunctivitis, uveitis. So again, this is another patient who has a rash above the angle of the eye, but there is no rash on the nose. There is no rash here. So that means the eyes are not involved. So you can see that the eyes is spared. Of the three divisions of trigeminal nerve, V1 is responsible for about 90% of the cases. So we can see another patient. This is the ulcer in the V2 dermatome, which is maxillary branch of ophthalmic nerve. This patient as well, from the angle of the mouth, the rash is distributed like this. Here you can see even the tragus is involved. So this part of the external ear and this part, this area is supplied by the mandibular branch of the ophthalmic nerve. You can see the subsequent oral mucosa is also involved. Here are the ulcers here. So always check the mucosa of the subsequent dermatome, because you have to give the management of this part as well. This is another patient, this lady, how strictly the zoster follows the midline division. Some rash can overlap on the other side because of the common innervation from both sides at the midline, but we can see the vesicles here. These are the crusting, and if you see the tongue, the lesion here intraoral is also midline. It is towards this side. This is rash free. So this is also V3, that is mandibular branch of ophthalmic nerve. So now in this patient, these are pictures of two different patients. You can see the rash here and you can see the level. This is shoulder. Shoulder is supplied by C5. Just at the mandible, you can say a bit of the angle of mandible is supplied by C2. The sternal level is C4. So, if you are asked which dermatome, you should know C2, C3, C4 and C5. So this is another patient having the rash over the posterior part of the upper limb. Towards the thumb it is C6 and towards the little finger it is C8. In between is the C7. So this dermatome will be C6, C7 and C8. In this elderly patient, we can see the rash over the external surface of pinna, which is very severe. This is supplied by C2. We can see the rash over the sternal area. This is supplied by C4. Between is supplied by C3. We can also see the rash over the tragus. Tragus is supplied by V3, the mandibular branch. A few rash vesicles over here. This is supplied by mandibular branch of ophthalmic. We can also see a lot of vesicles outside the dermatome. So if we count and we get more than 20 vesicles outside the dermatome, then it is known as disseminated zoster. This is an elderly patient, plus this was during the COVID era. So we got a case of disseminated zoster. Now we should know the supply of external ear because there is another condition known as Ramsay Hunt syndrome, which is due to the seventh nerve or the facial nerve. This is the seventh nerve supply. And if posteriorly towards the medial part, this is seventh nerve, sometimes vagus also. This part, the majority of the external ear is supplied by C2 via greater auricular. This part, including the tragus, is supplied by V3 via the auriculotemporal nerve. If we see the posterior part, this part is supplied by C2 via lesser occipital and greater auricular. Now coming to Ramsay Hunt syndrome. Before that, we should know herpes zoster oticus. Here there is ear pain and vesicles over the external ear. Where will be the vesicles? Where the seventh nerve supplies. Here the geniculate ganglion gets involved. The VZV reactivates in the geniculate ganglion. So we will have rash over here near the external auditory meatus. You can refer this diagram, for this is the facial nerve supply. This one and the base of the ear posteriorly. Vesicles will appear here. If this is associated with facial palsy, facial canal or the fallopian canal, the inflammation is so severe that the nerve gets pressed in this facial canal due to intense edema. So this will lead to paralysis of the terminal branches, the temporal branch, the zygomatic branch, the buccal branch, the marginal mandibular branch and the cervical branch, leading to these symptoms. This triad is known as Ramsay Hunt syndrome. The facial nerve also supplies the taste over the anterior 2/3 of the tongue. So there will be loss of taste sensation. The vesicles are very rare because the somatic supply is by the trigeminal nerve. So when the trigeminal nerve is involved, the vesicles or the ulcer will happen in this part anterior 2/3 of the tongue. When the inflammation is severe enough to cause inflammation at the internal auditory meatus, the eighth nerve will also get involved, the vestibulocochlear nerve, leading to vertigo, tinnitus and deafness. The ninth nerve, that is glossopharyngeal nerve, and the 10th nerve, which is vagus nerve, might also get involved in the inflammation. Now coming to the complications of herpes zoster. The first and foremost is post-herpetic neuralgia, the pain that occurs in that dermatome after 90 days. It may be continuous burning, aching or throbbing pain or intermittent shooting pain, sometimes as allodynia, that means a normal sensation produces an abnormal amount of pain. This PHN can be prevented by start of early antiviral like within 72 hours, and the vaccine Shingrix also has been seen to prevent the PHN. PHN occurs due to the nerve damage produced by the viral infection. This reduces the pain threshold and leads to spontaneous firing of the nerves. Zoster can also be complicated by secondary bacterial infections that may lead to scarring. Systemic complications like pneumonitis, hepatitis. Coming to another very important complication that is usually asked is isotopic wounds phenomena. At the site of herpes zoster, which has already healed, a new disease like lichen planus may appear. So the site is same, in different timeline, different diseases occur. There can be segmental paralysis. That means the muscles of the dermatome involved in zoster gets paralyzed. For example, there can be wrist drop if upper limbs are involved. With this, we have come to the end of today's class. Conceptual dermatology is what I aim for. We'll meet again in the next class. Till then, bye.